And we're live. Hello. Good morning. Good morning. Good afternoon. Hello, everybody. For those of you who are, I guess it's going to take a minute for people to join us here, but we want to welcome everybody to the podcast for the Neurogenesis project. This is Braincast number 3. So welcome, everybody. Drew, how you doing today?
I'm almost fully caffeinated, ready to go.
Okay, good. Likewise. I'm working on the hydration now myself, so we're in good company. All right, so you can hear me okay? We're good?
I can hear you great.
Great. Well, I'm excited about today's Braincast. We have a good, I think a good set of topics to cover. We've had some good responses from our first 2. In fact, I was just checking the stats just 2 days ago. Yesterday, we got a new comment, people starting to follow. So this is kind of exciting. We're at the beginning of something.
Yeah.
And I think you've gotten a lot of good feedback from your network about what we're talking about. And
we certainly have, and for our audience, particularly there's sprung up out in the Western U.S. a bunch of groups, particularly parents, who are very concerned about the recreational use of marijuana and how it's no longer a natural product. They're boosting the THC as much as 90% in some of the edibles. And kids are dying and losing their minds and becoming psychotic at times. And nobody seems to be paying attention to this. And I think it's the big money involved in it. This is a multi-billion-dollar business now.
Well, so this is
in Forbes to invest. So I've connected with these different groups, mostly parents, and our friend Aubrey Adams, who joined us last time, asked a few questions, has been really excited. And I've asked her if she would come on in the next 1 or 2. We're going to do one just on tell the truth about cannabis and marijuana and its effects in utero all the way to death, early death. You probably didn't know this, Sean, but adults who persistently smoke, and that's at least 2 times a week, have are 40% more likely to die before age 60. Did you know that?
You mean smoking marijuana? No, I didn't know that. Yeah.
And one of the theories is it's the endothelium is inflamed, which causes a sudden heart attack. And they test okay, but this happens and they just keel over.
So I think this is something we're going to kind of dive into in a little bit more deeply, because we're also going to be welcoming as a guest to our Braincast here Dr. Kolouri, who's a friend and a neurologist, and he has a perspective also on medical cannabis, and I think this is going to be we'll give people a little taste of maybe a debate that's going to come down the road, but also insights to educate people.
One of my favorite people, Dr. Kolouri.
Dr. Yeah. Kolluri, yeah, me too. So we're really lucky to have him as a guest. We'll bring him in a little bit. And just want to kind of get people primed for that. Drew, maybe you can tell me a little bit about the article that we just put out there to Sober World. So folks, and we'll include a link down below, but maybe you can kind of promote what we're just putting out there now.
Yeah, thank you. Dr. Orr and I combined, co-authored an article called Deep and Debilitating Wounds, the Effects of Childhood Trauma on Neuropsychiatric Disease. And it's an association that's undeniable now. And the amount of incidents of childhood trauma, that's including physical trauma, sexual abuse, neglect, abandonment, growing up in a dysfunctional, crazy family, increases the risk for substance abuse first and other neuropsychiatric disorders. PTSD usually emerges during the substance abuse phase. And these kids' lives are just shattered. And they comply and try to figure out why people don't like them. And then in adolescence, they act out. That hurt and pain and rejection turns into anger. And we're just seeing all kinds of things go wrong in this culture where I don't know if I think I've told you this before, the CDC about 7 years ago had to add a new cohort to their high surveillance risk monitoring. And it was for 10 to 14-year-old girls committing suicide. No, I never thought I'd live long enough where we had to worry and surveil 10-year-old girls because they were at high risk for killing themselves.
It's
And
tragic.
most of them, you back up and you find trauma in their life, and then addiction, and then depression, and then why should I live anymore? And it's quite sad. So yeah, we got this published. We all want you to take a look at it and read it. We made it very readable, and you'll have a lot of good information if you're interested in understanding the association between all these things, and addiction is right in the middle.
Well, I just want to thank you for the opportunity to co-author this with you. You know, I really have enjoyed blending our different viewpoints and different ways of looking at topics that affect brain health and brain function. And it was really neat to put
you
that
were
together.
incredible by adding the whole neural networks, the interface that becomes disrupted, and these people lose disconnect from their frontal brain where the best decisions are made, and they become hopelessly depressed, and then just hopeless.
Yeah.
And so thank you for all your help with that.
Sure. And for anybody that's really interested in digging into the underpinnings and neurobiology of this article does contain that information and links and references. Also, our Braincast number 2 that we did last week, we went into the topic of Reward Deficiency Syndrome more deeply, I think, than we've done before. So I would encourage anybody to look back at that if they're interested, and we'll leave links in the box below in the chat box below for you to take a look at it. So, where do you think this is going to go? You know, we've got a strong industry that's really serving up an increasing potency of product. There's a profit motive, which, it seems to me like, and when we bring Dr. Kolouri on, we'll talk a little bit about this too, but I think in terms of, legitimizing cannabis as a product in order to better control it, better regulate it, remove the black market aspects of it. But then there's a price that we're paying, it seems like, right? So what are you hearing from your network about that price? What are we seeing?
Well, when I was way back, almost 20 years ago, I was at the University of Florida in the Division of Addiction Medicine, where we were training fellows and residents. And I would travel around debating, quote, medical marijuana. And the facts were always on our side. They would use hyperbole and emotion and bring up some person who wouldn't identify herself or her illness and say, the only thing that helps me is this medical marijuana, government grade, which is about 4%. And I ended up being the mean doctor guy who was trying to take her medicine away when there's no evidence, not a zilch evidence that it helped anybody. And I think what Glenn will help us understand, probably the only benefit that happened was you got the CBD while you were getting the THC. And now we're seeing that break where you can buy just CBD for a lot of your aches and pains and things. And there isn't great evidence, but we're getting some evidence about some usefulness. And as you know, for these orphan seizure disorders and genetic seizure disorders, a Poladex was made from CBD, and it's working, and it's approved by the FDA, but it has no THC in it. Just one comment about how the media portrays this. When this happened, I saw a headline that said, constituent of marijuana stops seizures in children. No, cannabis stops seizures in children. Now, when you think cannabis, you're thinking marijuana, right? And so it's very subtle, but there's a difference when you say cannabis and marijuana. So you have to be very careful about distinguishing that, because cannabis includes everything. The high potent marijuana they're selling now has almost no CBD in it because they have to eliminate it to get the high potency. So that's what's going on. We're having this engineered, manufactured product where they've removed a lot of the beneficial CBD in order to boost the percent. You can't go above 100%. So the plant material is about 50-50, CBD and THC. You remove most of the CBDs so you can have more THC, which is causing psychosis and schizophrenia. And I have asked my patients, when you're on this stuff, can you drive a car? And they said, I can hardly sit. You know, I can't stand up, can hardly walk when I'm on this stuff. They call it wax or dab, and in the UK they call it skunk. And the hospitals are filled with psychotic young people in London.
So if you have parents out there who are contending with a child who's suffering with addiction from this, how first of all, how can they get in touch with you? Obviously, we'll put our links to the practice, but we've got a few different ways to get to you. But how would you prefer to be interacting with parents who are struggling?
Well, when for years I've had parents call me about their kid and want me to see them, and I always insist that I see the parents first, because I can tell them exactly what the kid is going to do. There's no surprise in this. Once I know they're addicted, they're very predictable. It's what the parents are going to do, and they have to make tough decisions. They have to get in and parent. If your child, 3-year-old, was running in the street, you would discipline them so they wouldn't get killed. And the same principle applies when your teenager's smoking marijuana. He's going to get hurt. She's going to get hurt. And you have to do something to make that choice more painful for them. I'm not talking about beating them. I'm talking about logical consequences. And each kid is different. The purpose of discipline is not to hurt a child, it's to change their behavior. Because your job as a parent is to protect them when they're younger, and eventually they'll like you. But your job is not to make them like you at the beginning. It's to love them unconditionally and protect them from harm. And then they end up loving you later.
So when a parent is struggling with an addicted child, I mean, you're really not, kids are not calling you to ask you for help. It's their parents, their grandparents, their aunts and uncles.
Right.
And your approach is to help them to understand exactly what they're grappling with, what addiction is doing to their kid, how it's modifying their behavior, and then set up a pathway for them to start to work through this process of discipline and feedback. And
there's another thing, you talk about this a lot. They're unaware of the damage it's doing to them. How their lives, so an addict's life has become narrowly focused each day on getting the drug. The parent's life has become narrowly focused and worrying about that kid. And everything else they're not functioning very well. Their mental energy and their anxiety is all towards this child. And the other child are getting neglected. The jobs are getting neglected. They're spending time searching, worrying. They don't go to sleep. And they're a mess. And so I want to explain why this is a family disease. If someone could just go out and take drugs and screw themselves up and not hurt other people, not many people would care. And that's your choice, the libertarian idea I'm not in favor of. But when you love your child, you would do anything to protect them. They just don't know what to do. And some of them conclude, well, maybe if I'm not so hard on them, make it easier. And, you've heard these stories about parents allowing drinking in their home and marijuana in their home. And I hear stories of kids who were raised with parents who smoked with them their whole life now.
Really? Wow.
Yeah, it's scary. So you and I have started, we're experimenting with this new coaching platform, and you're helping me get hooked into that. So there's a couple of ways. You can go to our website and contact me or Dr. Rohr. And then maybe it's premature to talk about what you've set up, but we have a portal where we can set up sort of coaching through Zoom and other in this particular portal, and we can do online stuff. I think you're helping someone in India right now. I think
I am. Yeah, it's amazing how our world is so connected now, and people are really hungry for information about how the brain functions.
Yeah.
And in our last episode, we talked about the neuroeconomy and my views on how this massive transformation that we're going through in our world right now really is the process of graduating from something that's been around for thousands of years, the cardio economy, to a new way of doing things. It's all really our essence is being digitized. Our life force is being put into a digital world. And so in the neuroeconomy, we're operating now in a level where our lateral prefrontal cortex is more precious than it's ever been. And so, so from a mechanistic standpoint, what I see with you and the clients you've been helping, and now that we're working on them together, understanding how important it is to get the mindset right about the way that we're thinking and taking action is critical, but then also having the physiological, mechanism working well is very important. And so I think from that perspective, it's been a lot of fun to collaborate with you. And now that we're starting to go into this new platform, which we'll leave some links, coach.me is, it seems like another, avenue, another distribution network that we're going to be teaming up with here. So it's another way of us getting the message out there and helping people to form better daily habits, to make meaningful changes in their life. It's hard. It is really hard to change. We're so wired to be a certain way, but sometimes a good, abrupt change, like let's say a viral pandemic, can create massive change.
Well, coaching serves a lot of direct, in real time advantages, but the other advantage when you're looking at behavioral change that is more difficult is, you've got an appointment with your coach coming up in a couple of weeks or a week or so, and you want to get a good grade. You want the coach who you have agreed to change some things. You feel somewhat of an accountability in the best sense of that word, and coaching is really important if you trust and like the coach, and we're very likable, trustable people, right?
Like to think so. Yep.
Yes.
Our patients and clients like us, and works out well. Yeah. So I think it's a good model. I think it also makes it a lot easier to have compassion for folks. We talked on our last Braincast about a patient who I'd been taking care of, and she eventually revealed that she was suffering from the effects of alcoholism and alcohol addiction. And we did genetic testing, and it revealed that she had about 5 different genetic predispositions all working against her. And the amount of relief that she felt, realizing that she was not suffering from some kind of permanent character flaw, but that really those decisions that she was making, they were really influenced heavily by her own gene makeup. It was liberating. You could just feel the weight come off her shoulders. Sure. And now we can set her up for a totally different and happier life to be productive in the neuroeconomy.
The parents that I talk to kind of feel the same way. They think it's their fault. What did I do wrong? Why is my child addicted to drugs, as if they had chosen this? Right. And part of it is understanding they love their child and they've done everything. And it's like, if I had cancer, all the love and support in the world wouldn't make that go away, So the idea of seeing it as it's not a malleable disease as we think we can just switch it on and off. It is, sure, there's neuroplasticity, and we see great recovery in people with drug addiction problems and alcohol dependency, but it takes some time, and it takes all of us, the coach, the family, and the person, pushing against the disease, not against each other. And once you can make that switch from fighting each other about where you're going, where is, all that stuff, we get all of us against the disease, which isn't anybody's fault, we make progress. Yeah. And part of my role as a coach, or when I was a clinician, was doing all that kinds of things with families. Let's us be against this addiction and disease, and we'll get a lot farther, a lot quicker.
Well, that sounds good, and I think being for healthy brain function,
yes.
is a way that I would personally like to frame it, and being positive about solutions that are coming online, and all sorts of even just supplement-based strategies that can help improve brain function and reduce the cravings that come with addiction. So it's going to be a very exciting time moving forward, I think.
Oh, it is.
Well, I think anything else you want to bring us our audience up to date from this last week and the new developments?
I think we're going to probably post that article on in the LinkedIn and Facebook and things, and on our website. So we'll have that up in, within the next day or so you can find it.
Yeah.
And I guess you can find it right there.
Great.
Good.
Well, I think this would be a good time to bring in our friend, Dr. Glenn Kolluri, and I'm going to go ahead and add you in now, Glenn, to our stream here. Hey, welcome.
Good, welcome. Thank
you.
Hello,
Glenn.
Hello, Dr. Drew and Dr. Shore.
Hey, it's good to have you, my friend. So, for those of you who are just joining us, Dr. Glenn Kolluri is an old friend. I've had the great opportunity of working with him in the front lines in the clinical arena, taking care of patients in a hospital setting. As I've moved out of the hospital setting, he and I have continued to collaborate over the years, and I've really just enjoyed watching him evolve as a clinician, and he's one of the most kind and compassionate physicians that you could possibly ever have, wish to know.
And smart.
So,
I hope so. He was just curious, ask a lot of questions.
Curious.
Well, so I think one of the reasons we wanted to bring you in here today, we've been collaborating on a lot of different things over the years, but now that social media and medicine really has become such a robust, activity, we want to share our platform with you and share your insights with the world, Glenn.
Sure.
This is a time of unprecedented change. And I think back a decade ago, I tried to raise a red flag about some of the concerns I had with the system. You're living in it now, and it's stark, full out, head-on collision with this pandemic is exposing a lot of the system's flaws. And I'm not meaning to predispose you in any way or put you in any harm's way by framing things that way. I'm really curious, and I think we're all curious about what is it like right now to be practicing medicine, in the hospital when you have already conditions like stroke, like traumatic brain injury, autoimmune diseases that are attacking the nervous system, and now you've got this new layer of complexity. Do you want to tell us a little bit about what your day-to-day is like?
Every day is a new challenge because we don't know a lot of stuff. We're learning as it goes along. We have no clear input about what to expect. For the other diseases like autoimmune and stroke, I can have a pathway. I have experience. I have previous ways of looking at things, but now with COVID, and I don't know what the impact is COVID's going to do towards somebody with a stroke, or is this a COVID-associated neurological disorder? Did COVID unmask something that happened before, and then suddenly, so epilepsy and stroke and are patients that have MS more susceptible to be getting inflammatory, and as they're immunosuppressed already. So there's a whole lot of unknowns here, and so every day is like a new. You walk in and okay, this is straightforward. Turns out none of it's straightforward anymore. It's not. It's getting complex, and now this is the first time in 20 years that we don't know as much. And go ahead.
Well, no, this is really good. So I'm curious, how then do you approach the day? If you're going in with, let's say you're going to be doing rounds, you're going to go see patients, obviously you're going to be called for kind of the urgent stuff first. But in terms of entering the hospital, you're going to have to put on PPE.
PPE. I'm the one neurologist for at least 2 hospitals, and they don't have any, inpatient neurologists. They're all outpatient. Mm-hmm. So I kind of don't go in a room unless I really need to because of conserving PPE. I end up calling patients. We set up a telehealth ability to roll the card in and have a laptop in and be able to examine them by video if need to be. Mm-hmm. And then coordinating a lot with the other patients, and especially the other doctors and the patients, nurses as well, getting history for them. So it takes a lot longer. I can't go in the room and look and say, hey, the lights are off and the curtains are drawn, and you have a migraine. I can't see that, so I have to have a lot more time. So instead of spending a reasonable amount of time seeing a patient, you're spending more and you're gathering more secondary data and secondary information to kind of come to a conclusion what's going on. And then you find out the person, you saw this person for a headache or something simple or something, and then they turn out later to have COVID.
So I would imagine that maybe a lot of the patients that might be coming in with unrelenting migraine are being turned away from the ER, right? Because the hospital doesn't want to have.
Right.
So how are you handling that? Does ER call you and say, I need some guidance, I need help with this question?
They try to call me for guidance. We do have a tele service available for ER stroke alerts, but if they're not a stroke alert, they'll call me to try to get some information. And most often they have to get admitted so I can actually see them and eyeball them and kind of figure out what's going on, or to get additional information if their headache. Sometimes it's the new headache, or sometimes it's just a migraine, or migraines that have recrudesced because of ongoing issues, or they were hypoxic and that's why their headache came on from being exposed to COVID.
So what are some of the ways that you differentiate then when somebody's coming in with migraine versus maybe their central nervous system is being invaded by viral infection? What are some of the hallmark signs that somebody out there might be wanting to pay attention to?
It's difficult. I mean, suspicion, just being suspicious. Were you around anybody? Could anybody else be sick? And could you have that? And then if there's any kind of, right now we're running on a little bit of gut feeling, and it's trying to figure out who, the neuro patient that needs to be COVID tested. And so, and then I'll scan them, and we haven't done any spinal taps yet, but there's some people that have been reading about overseas that are COVID positive in the spinal fluid and not in the sputum or the saliva or in the back of the nose. So that's really kind of scary. So I don't know how to go and figure that out. And brain lesions, unique brain lesions in COVID patients. And there was a paper about cytotoxic lesions of the corpus callosum, and I found one in Central Florida. And I emailed the author in France and said, here, I found one here. So they're getting information that way.
So you're seeing some patients who actually are developing clear evidence of brain damage from the COVID itself.
From the COVID itself.
And not from strokes, right? Because we know that COVID does two things. It creates inflammation and it creates blood clots.
Yes.
But you're seeing a third mechanism here where the virus is actually invading the brain and leading to some of the kinds of changes that we might see in somebody with multiple sclerosis, for example.
Right, and some things that are not very obvious to the primary team they're doing, so it's only being picked up. I've seen two. One lady did not test positive. I don't know how, but the other person was already COVID positive. So there was there's many people that I can see that I can try to decide. And it's hard to get MRIs because they have to get them at the end of the day because after all the routine patients are done where they're COVID negative, COVID positive, and go at night so they can take care of the machinery and clean it.
So that's a big change to the logistics, the workflow in the hospital, right?
It's a lot slower, and people are, it's full, and they're staying a bit longer to be able to get data.
So an extra length of stay can contribute to clogging up the hospitals because we're trying to figure things out. So what do you think maybe might be a way to help to improve the workflow, to speed the throughput and not sacrifice quality in the process?
Wow, that's a good question. I'm not really sure. I don't know other than increasing the staff, but people are getting burned out now, nursing staff and physician staff. And, initially I was trying to avoid going into rooms because we had limited PPE. So only for the nurses that really, and the docs that really had to go. I'm always a consultant, but if I have to see a patient, I'll go in the room. And, pronouncing them sometimes, that has to happen. That occurs.
Well, I have this is a naive question, but are some of the patients with COVID presenting like a meningitis patient? With
not a lot right now. Some of them that I see, they may think of a meningitis, but they're getting so much antibodies and steroids that
right.
not seeing a lot, or they're not talking about it so much, or if it's getting overlooked or not. But and everyone's a little bit shy about doing a spinal tap on a COVID patient.
Right.
It's hard.
Well, it reminds me when the HIV pandemic started, in the early days, I think a lot of HIV positive patients got marginalized because there was just so much fear about, getting contaminated and doing procedures and, who could get it and why. There's a lot of questions there. Do you feel a parallel to those days?
A little bit. I mean, I'm desensitized. I used to work in an HIV lab when I was in college, so I'm used to that, and so it wasn't really an issue, but it was really for getting equipment, right now. I think the equipment's better off now. Everybody's got gallons and stuff like that to supply. Before they weren't getting. And when I walk in, I have a mask. I have my own N99, and I have to cover it with another one. And I got a face shield, and that's an 8-hour day.
Wow.
Other than just, then I have to get done and then go to my little cubby hole and dictate, and then I can take stuff off and then put it back on when I go to the next hospital.
But you're also taking efforts to be very careful and cautious, and you're staying healthy and keeping distance, and you've
doing
been
my
very
supplements,
responsible.
and I got my both vaccines, and so do as much as I can.
That's good. So I think the vaccine. So you feel comfortable with the vaccine, then you would recommend it?
Yeah, I got my second shot Friday, and I had a little sore shoulder, but it went away. Some people are complaining of fever, so maybe they were talking about pre-treating with Tylenol before the second shot. The first shot was not a big deal at all.
Yeah, I've been asked numerous times by friends and associates about whether it's safe to get the vaccination and effective and all of that. And my feeling is from the data we're seeing so far that it is, and I'm encouraged by that. I think it's also if you have a choice between getting let's say a side effect from the vaccine or the full-blown viral syndrome where you might lose your sense of smell and actually lose brain function. I think I probably would choose to have some side effects from the vaccine myself.
And I'll throw in there also the side effects of a post-viral syndrome, which we have no clue.
That's a great point.
People understand shingles. Think of this like shingles. You have no idea what will happen in 20, 30 years. Even after the 1918 flu pandemic, there was a spike of Parkinson's disease in our neurology literature.
Right. Well, this is where
the same thing to occur.
Oliver Sacks in featured in the movie Awakenings, right? Got all the attention for defining post-encephalitic Parkinsonism that affected many people who had been affected decades before by the flu.
And
so,
we're only 1 year into this, and we have no clue what's going to happen. So I thought the risk of the vaccine being bothersome is minimal, and the risk of post-viral and post, the actual disease outweighs the risk of the vaccine.
Well, I think in a way this pandemic is the differentiating factor for who may thrive and who may not in the neuroeconomy. I've had a number of young people, college-aged kids who get sick, and the effects on brain function are stunning. Loss of cognitive capacity, fibromyalgia-like changes, major changes to sleep, to mood, to motor skills, the ability to learn. So, and those are subtle compared to somebody who totally wipes out from strokes and disease in the lung. But those are some of the lasting effects that are going to impair that person's future earnings and ability to get along in this new environment. So I think, Drew and I have talked about ways that we can help to improve the diagnostic process, use some of the new tools that are available from an imaging perspective to get a baseline to gauge the effects of treatment strategies that help to improve the production of new connections and new neurons in the brain. This could be this could be a catalyst for some really good healthy change along those lines.
Very interesting. Yes.
It's really exposed sort of we know the healthcare system was limping along or possibly broken for many years. And this really exposed a lot of bureaucratic obstacles in the way of patient care. And, people who go to the hospital for something are coming out sick sometimes because they get COVID in the hospital, and there's a lot of fear of that. But the implication for brain function is our friend Babak Khatib, who is a neurosurgeon, neurologist, and he's one of the leading guys in the world in brain mapping. He's done some research and talks about the effects on the brain are not acute; they're longer term. And
I agree.
He's one of the very leading scientists in this area of brain mapping, and he's concerned. And when I hear him talk, my ears perk up and I listen. So I think you're onto it.
Glenn, maybe you could give us a little bit of insight, kind of backing up from where you are now. What were some of your motivations early on that led you to be interested in neurosciences and convince you that you wanted to be a neurologist?
Well, it kind of goes back to my mom. My mom suffered a stroke when she was in the 30s and 40s. And I knew, that's kind of where my thoughts were. I wanted to do rehab first. And I said, well, why do I want to do rehab? I mean, it's kind of too late. We need to stop it before it starts. And that's how I got into neurology. And let me learn about neurology and neurological disorders. And, maybe there's something we can do beforehand and bring down the risk of the strokes, and make a change that way. So that's how I got interested into that field more than anything else. I thought
Sounds familiar, Dr. Orr.
Yeah.
Right. Yeah. Some of the audience might know that my brother had a head injury, and that stimulated me to go down the very same path of trying to figure out how we can do better to take care of the people. I think that's what I hear you saying is how can we do a better job taking care of people? How to do a better job?
I mean, really, what do we do to stop this? Really, it's not just to treat it, stop it. Yeah. There are people that don't have stroke. There are people that don't have diabetes and stuff like that. And how do we do to stop it? You got to fix the proximate cause. Just like the article you wrote about, children's trauma. That was the original, may have been the original trigger for later adolescence addiction, complications, and so forth.
So do you think I'm just going to say it, I guess, it seems to me like this pandemic has put a really fine point on just how important it is for us to curate our health well to prevent outcomes, right? I mean, anybody can get sick and from this and go downhill, but it does seem like there are certain people who are predisposed, and people with metabolic syndrome, with diabetes, with high blood pressure, et cetera, seem to succumb to the more drastic effects of coronavirus infection.
Right.
So
their ability to compensate. Yeah.
So what does it feel like to you now, looking ahead or catching up? It's been 20 plus years since you committed to going down this path. Do you think we're better off? Do you think we're worse off?
Stroke has made it down to number 4, and corona is on number 3 out of the causes, the leading causes of deaths, and stroke is on number 4. So we've improved a little bit, and we've got a bit of a way to go. It's improving. People are understanding, but trying to get people. My personal is, it tends to be diet and our ability to diabetes and hypertension. The big risk factors for stroke are kind of easily modifiable if we can modify those things. So,
good. So looking forward to the future, then, based on your experience and what we're seeing is kind of in many ways a collapsing market. I think you and I probably classify as old guys now.
Yeah.
I hate to say that. I think all three of us probably are in that. Sorry, Drew. We're all in that category of old guys now. They call them OGs. Apparently the millennials call us OGs. But I like to think that means we have more wisdom. Yeah. And so, looking ahead to the future, as there are a lot of our colleagues who are retiring, right, because they're at the end of their practice life and they want to enjoy some free time, or the environment's just too difficult, too hard to navigate, too contentious, full of threats to be able to practice medicine. And that list of threats is very long and distinguished. How do you see things moving forward then with fewer frontline neurologists out there? You cover 2 hospitals and you're the only guy. You're the only person who's providing neurological care, and that's not even 24 hours a day, right?
In a hospital, that's not 20. That's like kind of a, during the 8-hour day. I mean, even in the clinic setting, there's very few neurologists, or they're, some of them are getting retired and getting out of it, or old, or some of there's complications, and so. Feels like the number of us are dropping. We're getting smaller group, and so I don't know. I don't know where it's going to go. I don't know where they're training, or if they're training in the big cities and staying in the big cities, but they're not coming out to the smaller towns.
So you're faced with a prospect then that in your environment, and I would argue that you're not that different, from many other neurologists who are probably in, maybe not the biggest cosmopolitan area, but it's not like you're out in the sticks either. That you have a challenge, and that is to educate your colleagues, to educate the other physicians who are in your environment. Can you talk a little bit about that for a few minutes?
Well, yes, we've been trying to, have the primary doctor or the ER physician, kind of like, let's say somebody comes in with a seizure. What do I do? Sometimes a neurologist is not available, or they can't call someone to come in at that moment to the ER, or there's nobody on staff. And so kind of giving them a little bit of confidence in their assessment skills, just and trying to make it a short little blip, a little, thing so they can look at it right away and get somebody stable until they're able to be seen or transferred or something like that. And this, and it's like, I think it's not a lot different. I had to learn CPR, and I know how to deliver a baby. So I think maybe most physicians should be able to handle a seizure and stop a stroke, or
Right.
Stop a seizure and stabilize a stroke. Really.
That's a really good point. Yeah.
That's where it started with, and just giving them some comfort and confidence. It's not going to make them, board certified neurologists, just some confidence. And we started a little slide project that we can kind of think about, making it easy to access, and they can watch it in a few minutes and then kind of, get a big picture, a quick and dirty look.
So we've been talking about doing this project together, a medical minute,
Yes.
and especially the neurological perspective at first. And for those of you who are watching and may not be aware of this, every minute that goes by, hundreds of thousands of neurons will die in somebody who's having a stroke. And so time is of the essence. Mm-hmm. When somebody suffered a brain injury, whatever the cause, it's absolutely critical to get the right kind of therapies in line fast. And in many cases, it's just something simple. One little thing can make all the difference in the world. And so tell us a little bit about the medical minute from your perspective and how you think that's going to play out. And I'm just going to close this blinding getting blinded here. I'll be right back, but go ahead and tell us.
Well, the idea for medical minute was, I was watching the videos on magnetic physics, and it's like, oh, this is fascinating. I can learn physics in a minute and understand a simple concept and say, okay, this is pretty cool. So I started watching the series. And I thought, maybe we could do that something in medicine, so we could kind of make a little minute video, put it together, and let's say the first thing I'm thinking about is seizures. How do you identify a seizure? Because often this is what I get called from in the ER. It's like somebody had a seizure come in. Well, okay, tell me what they did. Or I don't know, maybe it's a seizure. So trying to get number one, identify the event actually, and then we break it down to the three simple categories that it can be, and then you can make a decision there. So a seizure doesn't, so they have a comfort level in understanding the seizure, and then they can decide when to get it. Because if you stop the seizure right away in the ER, you're not waiting for them to show up in the ICU where there's, and you may not have a neurologist till later, or anybody that has a comfort level in doing seizures, or in then stroke would be the next thing. And then the most common thing is passing out. The person passed out. Well, okay, what do you mean? Let's go dig in. So that's kind of the basic idea. It was geared for hospital-based patients, hospital-based staff that has maybe they didn't rotate through neurology, maybe they didn't have any comfort level. They need to know how to do the seizure and sort of, instead of just giving them some time and correcting something, and while they're waiting for an expert opinion to come along and be able to do it. Because there's just again less of us available, and the ones that are available kind of stay now in their clinics. They don't want to do hospital work as much.
So this is really exciting. From a certain point of view, one of the great things about this time that we live in is that things are happening exponentially fast, right? That we're seeing solutions scale up. We're seeing financial changes happen at a very fast pace, faster than it's almost capable of us to even understand in some ways. I'm a big fan of disruptive innovation. I have been forever, and it's gotten me in a lot of trouble here and there in a good way as we're trying to change the system. But I almost see this as a great opportunity for you to get education out there to a large number of people and democratize some of this information that has been locked up in our specialty for a long time for a good reason. It's part of what makes neurologists unique, is that we can do things because of our perspective, and we can help a lot of people. But now we're seeing as a pandemic has scaled up, our solutions haven't scaled to match. And I think educating the masses is something that is being rewarded on a massive level right now in many different ways. So I think this holds a lot of promise, and I would look forward to supporting you and working with you on this project.
Thank you.
And especially since we have an expert in education in Dr. Drew Edwards. He's, the guy when it comes to education. So we're very, very fortunate to have this team together. And I think it'll be interesting down the road to also feature some of the newer devices, disruptive innovations like the Cerebell EEG, rapid EEG detection device. And we can talk about that in a future episode. But a lot of neat solutions coming online.
I was listening to you talk, Dr. Kolouri, about sort of people are, in my experience, is people are coming in for, by the time you get to the hospital, you are very sick. And there used to be something called doctor's orders. Do you remember that?
Yeah.
Doctor's orders meant the doctor made a decision and it happened based on his or her clinical assessment.
Decision,
That's
right.
not true anymore. It's insurance orders and payer orders. And so you don't get to the care you need without really going through so many different hoops. And that's affecting everybody, where we've just accepted it as they're in charge of patient care. And it's, I've seen it firsthand. And I remember the day, I'm old enough where the doctor could say to the older woman who had a gallbladder taken out, he says, well, I know the family and it's pretty chaotic right now. I'm going to let her stay in the hospital another day, because he had a relationship with the family, and nobody batted an eye. Grandma was happy, doctor's happy, the hospital's happy. And then we had the Medicare Improvement Act in '91, which made nobody happy.
Yes.
And so the idea of this innovative and this disruptive is trying to go back to a place where a skilled medical professional can make skilled medical professional decisions that will benefit the patient early, before they get beyond
Right.
I see people coming to see me. I had a 15-year-old girl came on. She has 2 incurable STDs. She's depressed. She's suicidal. She's addicted to marijuana, cocaine, and alcohol at 15. Well, that's like coming in with stage 4 brain cancer. The outcome is already determined, barring a miracle. And that's what we're seeing in medicine, I think, way too often, is we don't get them to the proper person until they're so sick. And where the survival rate is very challenging then. I'm being overly general. I know there's exceptions to that, but that is really bothering me from the people I know I've lost friends because of that kind of behavior.
I want to go back to and I like what you guys are saying as far as going back to treating the patient, not just the disease.
Right.
You must treat the patient as a whole person, not just the disease as stroke or MS or something like that. And that's what this automation has probably taken out of.
Yeah, thanks for bringing that up. I think, I reflect back on when I started. I think you and I both started around the same time. The decade of the brain was taking off. We had the National Institutes of Neurological Disorders and Stroke receiving billions of dollars of funding to generate solutions for diseases. And it was very impactful, what was done at that time. But I think I personally came out of that decade of the 90s thinking we're going to be armed with medications to go and cure disease and eliminate suffering. And while many of the medications did help to reduce the impact of symptoms, a lot of times they didn't deliver as promised, or they would backfire for some reason. And I can say just personally, it forced me to reevaluate, what is going on here? Why is it that, I might give somebody with Parkinson's disease a particular medication that's supposed to, impact their symptoms, and sometimes it, just doesn't work. And I think I found so often the missing piece was a nutrient, or it could be a lack of activity. And something as simple as getting them on a bicycle made all the difference in the world, because guess what it was doing? It was creating new brain tissues, and new connections. Something as basic as treating sleep apnea would improve oxygenation of the brain at nighttime and help to prevent some of the unnecessary damage that was taking place. So I think it's taking a step back, and I consider myself trained as a super subspecialist, right? Working with some of the leaders in the world on neuroendovascular therapy, snagging blood clots out of the brain and putting people into hypothermia in a critical care unit. That's very, very specialized. And now pulling back to the 30,000-foot view and saying, how do we prevent that stroke in the first place by applying a comprehensive, thorough approach? Other people call it holistic or integrated, and those are all great terms, but unfortunately they've also developed their own seasoning that makes it hard for a lot of allopathic physicians or osteopathic physicians to accept those terms. But really, we should be thinking from a comprehensive standpoint all the time. So, we could talk about that all day. But you mentioned something earlier too, Glenn, in terms of burning out. And I'm curious to know, on the front lines, how are you interfacing with staff who are burning out? How are you keeping yourself mentally healthy in this strenuous environment, if you don't mind sharing that?
Well, staff, recognizing it in others is probably the first step. I mean, and nursing staff, they're golden. They need to be, you have a physician staff, but nurses are on the front line, and recognizing them. I mean, I can only, make sure they're treated well, sometimes a little bit of humor, sometimes a little bit of kindness and good words, and what you say impacts their lives. So what comes out of your mouth and how it goes, and let's work it together, and that kind of stuff impacts the nursing and as well as the physician staff. So positive feedback for them and positive feedback in any situation that they should be able to handle. And as for myself, just kind of going, and you have to have that time at the end of the day, maybe an hour where you can decompress and go for a walk or try to meditate or do something with music and do something like that, because it has to come out. That can't live in you forever. And if it lives in you, it builds up in you, and then you have issues, and then you can't become a good person to continue to help the patient that's suffering. The whole point of you to be there is to help them relieve their suffering, whether they have a stroke or a migraine or something else. To understand that, and sometimes you have to refocus and put your compass back to where it needs to be.
Great. That's just beautiful advice. And I hope a lot of people hear this and take it to heart. Maybe we could kind of wrap up this next little segment with just a bit of a shift. I'd like to just take advantage of the fact that we have you here. And I think you've given us some really great insights, and really just want to continue to encourage you to keep going and doing what you're doing. It's really critical. On the medical cannabis or medical marijuana front, depending on how you look at it, do you feel like giving us a little bit of insight? I don't want to put you too much on the spot here, because
no. I mean, I was listening to Dr. Drew's comment, and I agree. I mean, a lot of things. I got my license really to do it, but it was just curiosity, and mostly of getting the license part was really to understand the legal part, and learning how to dose it and write it is really not included. So I have to do that and learn what's going on. I think. I don't know what the best analogy, cannabis and marijuana and how they're messing up and having more THC, and that's causing disease. The difference between, as I learned in medical school, the difference between poison and medicine is the dose. So trying to understand and make sure that maybe that dose of THC that they're using in manufactured stuff to get people high is damaging. And even aspirin is the same way. Aspirin comes from tree bark. A small amount extends your life, and too much you'll die. So the same thing. So I thought maybe cannabis is like the poppy seed, and marijuana is now like the oxycodone, and that's kind of where. So I think if people are suffering, I think the neurological disorders that cannabis is kind of approved for, like epilepsy and maybe a little Parkinson's and pain. And if there's deficits, I can see a role in that. But for entertainment, and you got a normal brain, it's going to do damage.
So when you and I worked together 7 or 8 years ago in the hospital setting, I remember seeing a fair number of people rolling through, and this is before the industry had really kicked in. People coming in during the bath salts craze. A lot of times also with THC in their system and having really bad seizures, brain injury. And sometimes it was hard to parse out how much of this is the toxic effect of the bath salts versus the THC. But even THC alone, I would see people coming in with complications, encephalopathy, delirium, psychosis, and or worse. And so, are you seeing any of that now on the front lines?
Before 6 months ago, really not. But ever since the pandemic, things have kind of changed. It's really, and I'm just to enter one example of one. I cover 2 hospitals in Central Florida. There have been a couple of cases, not 3, when I was doing things that some patients are doing their medical marijuana, they're smoking it like they used to, as usual, they're long-term smoke, and now they're having complications. They're dying. I've had about 6 patients in the past 6 months between 3 hospitals that have had the same pattern: regular cannabis users, marijuana users, and suddenly they'll have a cardiac event afterwards, and I don't know where it's coming. I don't know if this is a symptom where they're getting a bad supply, or things are changing, or they're overdoing, because now with the pandemic, you're seeing a spike now of people overdosing in all sorts of things, as they have inability to compensate for their stressful events at home. So
something that I kind of put together a few months ago. I did a CME for a psychiatric journal, and because THC is a lipid soluble substance, it gloms onto the anandamide receptor in the brain. Of course, anandamide wasn't discovered until I think the late 80s by Johns Hopkins as the receptor for endogenous cannabinoids. But when THC attaches to that receptor, anandamide can't work. And anandamide is a very powerful, widely spread neurotransmitter that does all kinds of positive things for us. So not only do you get the psychotropic effects of the THC, but you also don't get the benefits of anandamide when you're smoking a lot, because the receptors have no room anymore for them to attach. And I think we're going to have to start looking at that as more of, it's not just the addition of the drug, it's the subtraction of the anandamide and its function.
Yeah.
Think of turning off a neurotransmitter in your brain, and what would be the result? This is maybe the most abundant one we have, one of them anyway.
And your comment earlier about the endothelium being inflamed, cardiac arrest, now has kind of popped up into my head about these marijuana users long term, but something's changing, and I don't know. And so that's going to be something we have to look at. People are coming in with the story of cannabis use, but drug screen's clean.
Yeah.
Really? Oh, that's interesting.
My observations only, obviously, but if anybody that's watching has the same experience as a neurohospitalist, then we got to talk.
Well, it's funny because I tend to think of CBD as having anti-inflammatory properties, and I think this is one of the, for those of you who are not aware, marijuana has 2 different components, THC and CBD, all of which we would consider cannabinoids. They're very similar molecules, and we think of CBD as having anti-inflammatory properties, whereas THC has a hallucinogenic properties. What struck me was that I learned this not long ago, that CBD, if it's heated up, will change its conformation to become THC. And so it does kind of beg the question, how much of CBD versus THC are people really getting when they're smoking it as opposed to eating it? It makes me wonder if maybe if it's a high potency blend or version already, and a lot of that CBD is getting converted to THC, maybe we're seeing super toxic levels that are just not within the range of what people would normally have seen recreationally.
Do you think the converted THC might be more inflammatory?
I wonder. I think it's worthy of some investigation. So
that would be a pathway for them to have a cardiac events.
That's one of the theories behind the idea of endothelium, and with their sudden heart attack and they die. But they don't appear to have heart disease prior to the event, which is interesting. So, but who knows? We got a lot to learn. But unfortunately, we're not letting the FDA go through its normal procedure of looking at this as a drug, whether it's safe and what is the efficacy. It's just being legalized by the ballot box, and no drug should be legalized by the ballot box. And
Well, yeah, it's. I mean, there's the political layers, or there's so much influence of
It'd be interesting to see
lobbies.
how.
So
It'd be interesting how other countries do it because it's been around for thousands of years.
mhm.
And are we just seeing it now in the United States, or is this something that other countries like China, India, and Indonesia have
Sure.
had the same patterns develop, or are their THC levels just so 4% or less, and they don't have the complications we do, or is it just industrialization of the drug that caused this?
That's a good point. It's a good point. You think of our two legal drugs, alcohol and cigarettes, they kill 400,000 people a year.
Absolutely.
They're legal. And when you legalize a drug, you're basically saying it's okay. And so young people see it's okay. And we had this prohibition against marijuana for a long time. And that prohibition has been lifted, and people don't believe it's harmful. There were just some of the shops in Colorado were recommending cannabis or marijuana to pregnant women for morning sickness. It may work, but they're having babies with shorter stature and smaller heads and smaller brains with this really unique kind of colic that went on for a long time. And if you want to have a small brain baby, then smoke a lot of marijuana,
Yeah,
but
wow.
70% in one hospital in Colorado, the women were tested positive for marijuana at the point of delivery.
Wow.
And that's scary.
That's scary, yeah.
Well, thalidomide did a great job getting rid of morning sickness too.
Yeah.
We found out the hard way what that did. So I think, again, as we're trying to encourage people to pursue better brain health so that they can be happier and more productive in the neuroeconomy, part of that is removing, toxins from the environment. So
Yep.
I think everybody here can kind of, whoever's listening can take their own view of this. But when you put it in the larger picture of trying to improve brain function, it's really hard to see too many other ways around what's right to do. So, well, this is great. Thank you. Thank you very much, Dr. Kolluri, Dr. Edwards. This has been great. I would encourage anybody who's watching to please like and subscribe. Please feel free to share this with your friends and colleagues. We hope to spread these concepts and bring a greater awareness of what it means to have high-level brain function. Whether you're somebody who's rescuing and recovering from some form of injury, or if you're a high performer who wants to expand and enhance your cognition, we have solutions for both of those sides of care. So any closing words from you guys before we close out?
Thank you for having me come on.
My coffee cup.
Interesting.
It's all good.
It's all good. It's all good.
All right. Well, thank you, everybody. Have a great day, and we'll look forward to the next one.
Thanks.
Thanks, guys. Take care.
Bye.
Bye-bye.